Hi, my name is Gary Ludwig. I'm honored to serve as President and Chair of the Board for the International Association of Fire Chiefs. This is our 6th IAFC Coronavirus Task Force webinar, so I welcome everyone who is joining us today. We conduct these every Monday at 4 p.m. Eastern Standard Time. I want to thank all our panelists who are joining us today on this webinar. They have a plethora of information, and I'm sure you will find quite useful what you will be provided today. The IAFC leadership the IAFC represents the leadership of 1.2 million firefighters and over 30,000 fire departments in the United States. We also have members in Canada and other countries around the world. Our Coronavirus Task Force is chaired by Chief John Sinclair, and he has a large spectrum of subject matter experts on the task force that continue to push out timely information on the coronavirus, including the use of these webinars. The chair of our Economic Task Force is Steve Pegram, and I have a working fire, and we turn that down, is Steve Pegram, and he will be joining us on future webinars. Today we'll have John Sinclair, Chief John Sinclair, Dr. Jim Augustine, our Government Affairs Representative Ken LaSala, Dr. Cristina Baxter, and Mike Ragone from Global Medical Response. He'll be sharing information with us about New York. Today we are broadcasting over voice internet protocol technologies through your computer and speakers and headsets. So please make sure your speakers or headsets are turned on and the volume is turned up. If you have any difficulties, please contact WebEx at 866-229-3239. Now my pleasure to introduce your first speaker of today, and that is Chief John Sinclair, who is the chair of our Coronavirus Task Force. John, you have the floor.
Thank you, President Ludwig. I just have a few short comments before we get to our very knowledgeable panelists. There's a great deal of discussion going on in different communities about how to open things back up. And I think that because of this, there's a couple of things that fire chiefs need to be looking at. In those areas where we are not seeing people or governors decide to open back up, we're beginning to see some cracks in the social contract, and we're beginning to see some organized civil disobedience. I would urge all fire chiefs to contact their local law enforcement agencies and figure out what your working doctrine is in the setting of civil disturbances. It is certainly our hope that we don't have significant civil disturbances, but I think that it is very important that our colleagues in the fire service touch base with their colleagues in law enforcement to make sure that you know how you're going to jointly respond. We're going to hear about testing and PPE from our panelists. The one other thing that folks need to know and understand is that at another level, we have been working with the Department of Interior and the U.S. Forest Service and the Association of State Foresters to take a look at what fire season is going to be in the setting of COVID-19. We are working with those groups to take a look and see how we would in-process folks into fire camps. Maybe we lay out fire camps different. But the bottom line here is to remember that this year, fire season is going to be complicated by the fact that we will have COVID also hovering. So one of the pieces of information that is coming out of the working groups is to really double up efforts and make sure that we jump on all of these fires to help keep them small, sort of an all hands, all lands approach to fires, and certainly for the Western United States, that's going to impact us. So with that, I will not take up any more time because we've got a lot of very good information from our presenters, and I will kick it back to you, Mr. President.
Thank you, John. Appreciate that great information. I want to take this opportunity to remind or talk about to all our listeners that we will be sending out an email blast to all our members who are members of the IAFC on a survey. We're conducting a survey of what has the impact that the coronavirus had on your department economically. Two areas of interest that we're really looking at is the cost of your response to this and impact on your local economy and your budgets. I'm hearing from a whole bunch of different departments, a whole bunch of different chiefs, that they are already beginning to talk about laying off firefighters. And that is a travesty at this time. We should always have a ready response force ready to go in the event that we have another emergency in our community or another pandemic. It doesn't matter what it is. Volunteer fire departments have been unable to fundraise. They've been impacted. It is across the board. So there will be an email blast coming out next week, and I strongly encourage you to fill that out and tell us how is the impact on your department. We will then use that data as we go up on Capitol Hill and ask our legislators and ask our leaders in this nation to help us through this crisis. So again, watch for that survey to come out. Our next speaker today is another good friend of mine, Dr. Jim Augustine, and Jim's going to talk about some of the medical components, again, the aspect of the latest information that we have on the coronavirus. So Jim, you now have the floor.
And good day, everyone. Thank you, Chief Ludwig. As you go to respond to your structure fire, they just dispatched a multi-company brush fire in our Southwest Florida district, so the season has begun down here. My presentation this week is going to feature a couple of items. One of them is the questions that came in from last week and a few more responses and guidances to them. And second, very importantly, is about testing and the testing process that is growing and frankly becoming more effective for both patients and for the members of our staff who are critical and essential workers. We have talked about monitoring our own staff and very importantly, it is a symptom check and a thermometer that checks our staff members to see if they are safe to go on duty today, to be around their fellow fire EMS workers, and then to go home and be safe for their families. So for us, it's a symptom check and a thermometer. For the patients, ongoing science says the best way to assess a patient to determine how sick they are and their need to go to the hospital is a pulse oximeter. So adding the pulse oximeter to your first responders and to, frankly, the only thing that needs to go within 6 feet of most patients in terms of equipment is a pulse oximeter. There are a growing number of studies that are beginning to appear that look to see what the expanse of the virus has been in our community so far. And a very well publicized one that came from Stanford in California says that a larger percentage of people, Americans in this case, have been exposed to this and on blood tests have shown some signs that they developed some form of immunity. We don't know what form of immunity yet, but you're going to be aware that some population-based tests are beginning, and that will help us understand what the expanse of this virus has been in America already. Next slide. Another question that came up last week was the changes in regard to management of cardiac arrest. And in that discussion, some people were saying our rates of cardiac arrest have increased significantly, and in some communities it's decreased. Whatever it is, it has been notable to a lot of people that our cardiac arrest population is increasing. For those of you in the high impact areas, and in our case, amongst the Eagles, which are the big system fire EMS medical directors, The New York City, Detroit, New Orleans departments have noted very significant increases in cardiac arrests. They will attribute that to both the direct impact of the virus and the people that are ill with it, plus the impact on the medical system. Why I want to let all chiefs know about this is as we go through the next couple of months, be aware that people have both actively avoided the medical system and in some cases passively as appointments got changed or canceled and they could not go for their routine care, for their cardiac disease, for their diabetes, for their hypertension, et cetera. At this short interval, we have seen some decrease in the impacts of strokes and MIs. We have certainly seen big decreases in trauma. But if people are avoiding their preventive care, there's an implication of that on the back end. And in some cases, a double impact of both disruption of the medical system and the coronavirus have resulted in significant increases in cardiac arrests. I just want you all to be aware as chiefs and be able to pass through your ranks the possibility that cardiac arrests are going to occur at a very different rate. For the most part, they have been increasing, but in a few communities, they have been decreasing in the short term. The impact also on our methods of resuscitation and on termination of resuscitation has been very important. Next slide, please. The AHA updated their guide to all levels of cardiac resuscitation, so basic life support, advanced life support, and in particular, they have talked about the need to terminate resuscitations if there's no chance that this is going to result in a better outcome for the patient and where there's increasing risk for the providers. So the longer that you're bagging somebody, the longer that you're compressing their chest, the more likely it is that they're expelling the virus and can make your employees and those that are serving as rescuers sick. Therefore, termination of resuscitation, which in many of my communities has been a part of our cardiac response for a long time, and an appropriate time, asystole, and some other indicators that this person has no viability left. We consult online medical direction and we terminate the resuscitation in situations where the family can be prepared for that. That's a really important new aspect in other communities and should be discussed with both your general medical community and your medical direction. Next slide. Every week we talk about our personnel health and safety and with updated guidance from the CDC, making sure that we stay safe in the common areas around our stations, that we check for symptoms that are routine with coronavirus at the beginning of the shift or when they arrive for a call. We do an objective test, which is a thermometer test to see if they have a fever. And then each member of our crews is able to do that. If they're on a shift schedule, they do it about every 8 to 12 hours. Most departments are having them do them every 12 hours. And then record those and keep those so that we make sure that we're doing the right thing for our own personnel. Next slide. 10 days ago, the CDC updated their guidance about essential workers and said an exposure does not require 14 days of quarantine. It requires instead 14 days of symptom monitoring and temperature taking and a mask on when in public areas. Next slide. All right, let's get into testing. And the testing options now are a swab in the nose or the throat that checks for presence of the RNA virus. So that's called a PCR test, polymerase chain reaction test. It begins with a swab. And in the shortest of these, like the Abbott test, within 10 minutes, it will be a negative. Within 10 minutes, it'll show positive if coronavirus fragments are present. Within 15 minutes, if the test is negative, there are none of those fragments that are present. So that is a direct test for the virus. In addition, in the past week to this testing modality is what they'll call a saliva test. And that saliva is, they give you a cup and you spit into it. And you spit a certain volume. and you spit in a way that it clears your nose and your throats to the best of your ability. And instead of the swab going in your nose or your throat, you're bringing the virus out and presenting it in a cup. Some of you are familiar with sputum testing, where they ask you to cough very deeply. That's a different form of a test, and in people who have only the dry cough of coronavirus, that will not be beneficial. We use sputum testing for something else, and that's for pneumonias. In the early circumstances, saliva testing is likely as sensitive as putting the swabs in. So you will see saliva testing for the virus as a new method of testing that will become more common over the next couple of weeks. Next slide. The other type of testing then looks for our body's response to an infection, and that is we produce these proteins called antibodies, and we produce several versions of antibodies in the short term and in the long term. The antibody testing has come on like gangbusters. So we have a large number of companies. That number is now over 130 companies that have applied to the FDA to market tests where a small amount of blood is used to test for antibodies. The antibodies are supposed to be for the new form of the coronavirus, the COVID-19. In fact, some of those tests have not been able to distinguish between old coronaviruses that people have been exposed to for many hundreds of years and cause simple colds. And your body has developed the antibodies to those probably when you were a child, and they continue to be present the rest of your life. So there's a problem in some of these test cases where they haven't been able to distinguish between old viruses and the new virus that we're most interested in. Over the weekend, the FDA released resources for healthcare providers regarding this type of testing. There are 3 documents that I have given you the links to that are the FDA fact sheets on antibody testing. The bottom line for all of these is, yes, there are a number of tests coming onto the market. Yes, there are a large number of companies who have applied for permission under Emergency Use Authorization to market their tests. There is only one of the tests that has gone through a more rigorous FDA evaluation, and that is not done at point of care. It is done in a lab. And so far, we don't have good science on all of these tests that are being put in front of you. Next slide, please. So these tests will come with a little card and a request for a couple of drops of blood, or about 20 microliters, so very small amounts of blood, and a test for the presence supposedly of IgM, which is the short-term antibody your body produces, and IgG, which is the long-term antibody that your body produces in response to infections. Those antibody tests supposedly tell the individual if they have been exposed to this bug and if they've developed antibodies to it. Next slide. Those antibodies go up in a predictable way in most cases. We don't know exactly because this bug hasn't been around, this coronavirus hasn't been around long enough. Nonetheless, we believe that you will see a spike first in the viral antigens, so the swab test or the saliva test, and then an increase in IgM as your body begins to develop in a response to this, and then IgG in the long term. Next slide. That will result then in a curve, which would take you through, and based on a positive, negative, positive, negative, positive test would tell you where this individual that you're testing is in response to a coronavirus exposure. If the test is negative but the antibodies are positive, it says this person no longer has the active infection. They build a response to it. In some cases, they have the virus, so it shows up on the swab. They don't have antibodies yet, which means they're very early, and the typical wait time for antibodies to show up is about 14 days. About 14 days before they will show up on a test. So the antibody testing has not been useful in people who are acutely ill, but it will tell us who perhaps has defenses against the coronavirus moving into the future. There is one more problem I want to show you as through this slide. We are beginning to find individual cases where firefighters, in our case, are showing signs that they persistently have this virus present in their nose and throat. These and other disease states are called carriers. And some of you are aware that you carry MRSA, or you carry a strep, or you carry meningococcus. It doesn't cause you any infection, but if somebody tests by swabbing your throat or swabbing your skin, they find these particular germs. So those are persistent carriers. And in this case, all we can call them is persistent shedders, because we don't know if these people who they swab 2 weeks, 3 weeks, in some cases 4 or 5 weeks later, their symptoms have gone. They were ill at one point. They now have no symptoms. For some reason, someone swabs them again, and the swab comes back still positive. Do we let those people go back to work? Do we let them go back to work without a mask? Do we tell them that they're infectious still to their family? These are questions we don't have an answer to yet, but you should be aware that if you're testing and moving into PCR testing for individuals in your department, there may be 1 or 2 of these people who come back with a swab that is positive weeks after their initial illness. I want to make you all aware of that. Final slide, please. So we are building a time sequence of asymptomatic people, mildly symptomatic people, through to those that get critically ill. How does our body respond? What are our ways of being able to find these cases, identify them early enough, prevent complications or death, or in some cases know that they have built immunity and that they're safe for some period of time. We will not know for a while how long people's resistance to this bug lasts, because it is a new bug. And we are not clear yet if IgG implies a month of resistance, a year of resistance, or a lifetime of resistance. So all that is science that is to come yet for us. I thank you for this opportunity. Please keep sending me your questions. And over the next couple of weeks, we will evolve to know more about how the serology testing gives us information that we can use to help our members and the patients that we deal with. And then over time, how that will help us return our communities to their normal state of business. Chief Ludwig, thanks for the opportunity, and I'll turn it back to you.
Thank you, Jim. Appreciate all that useful, timely medical information as it relates to the coronavirus. Now I'm going to turn it over to our Government Affairs Director, Government Relations Director, which is Ken LaSala. And again, Ken is storming the doors up at Capitol Hill on behalf of the Fire Service and the IAFC. So, Ken, thank you for all you do, and you now have the floor.
Thanks, Chief Ludwig. I just have a couple of quick things to update everyone on this week. I think we're going to move over to my slide. Basically, tomorrow, or as early as tomorrow, the Senate may be voting on what they call the third and a half COVID-19 response bill. Basically, this comes from an attempt last week by Senate Republicans to put more money into the SBA programs, the Paycheck Protection Act, and then also the economic disaster loans. Both those programs have run out of money, so they need to be replenished. There was an attempt to, I guess last Thursday, by Senator McConnell to basically pass legislation to refinance those programs. It was objected to by the Democrats, so they spent a weekend trying to work things out. So basically what we're looking at, and the details are still being worked out, but it looks like in the Senate this week, probably tomorrow, a bill will be passed that will have $300 to $350 billion for the SBA loans, including the Paycheck Protection Program. It also includes $75 billion for the hospitals and probably another $25 billion for testing. It's important to point out that the nonprofit volunteer fire departments can apply for the Paycheck Protection Program, and then also possibly for the economic disaster loans. So we'll definitely let people know once that legislation is passed. Going forward too, is talking about some money opportunities here. On April 28th is the due date for the Emergency Management Preparedness Grants. There was a special $100 million that was appropriated in the third COVID response bill to the EMPG program. Basically, what it will do is fund things like mitigation activities to slow the spread of COVID-19, integration of emergency management and public health operations, collection and display of public, private, and governmental data of hospital bed and ventilator capacity and usage, collection and display of personal protective equipment inventories and establishment of burn rates to forecast future needs, planning for alternate care sites, identifying all sources to surge medical professionals. So those are all eligible sources of funding. The application has to actually be filled out by either the state administrative agency or the state's emergency management agency. There is a 50% cost share. However, if a fire department and a fire chief is also the local emergency manager of their jurisdiction, there may be some opportunities here for you. And so definitely get with your state emergency management agency to start finding out how they're going to fill out their application. The application is technically due on April 28th. However, according to FEMA, the state EMA basically has to start on the application on April 27th. Also, the SAFER grant applications are due on May 15th. This is actually the fiscal year 2019 funding. It doesn't necessarily connect it to COVID response, but nevertheless, it does create an opportunity for fire departments that they're looking to hire new firefighters or to volunteer departments to do recruitment and retention campaigns, especially this year if you start to see some of the economic effects of the social distancing orders or, with the concerns about COVID-19, if you start seeing your volunteer base starting to shrink, there may be some opportunities here to apply for a SAFER grant to help you meet those shortfalls. Going forward, it looks like going to be a fourth COVID-19 response bill. We are currently lobbying Capitol Hill to address some of the issues of the fire and emergency service needs, including we're asking $5 billion each for the AFG and SAFER programs. For AFG, we're asking for funding for supplies like everything you've heard about, N95 masks, personal protective equipment, sanitizing agents, everything like that. And then for SAFER, we're looking at trying to use SAFER both to fund some of the costs of quarantining firefighters and some of the personnel costs like overtime and backfill, and then also to waive some of the requirements of the SAFER grant program so that that funding can be used to retain firefighters, much like it was right after the Great Recession. So that's some of the stuff we're working on. Also with the fourth COVID bill, we're lobbying for legislation to protect the jobs of volunteers who may be deployed to respond to COVID-19 or who may be quarantined due to their volunteer service. Also, we're asking Congress to repeal the requirement to auction the T-band. And then also we're asking for the, basically to make the Volunteer Responder Incentive Protection Act to make that permanent so that local jurisdictions can start giving bonuses and incentives to their volunteer firefighters, which include things like property tax benefits and up to $600 in other benefits. So that's what's going on Capitol Hill this week. We've also been holding a lot of briefings. Chief Ludwig, Chief Sinclair, and Chief Pegram, the head of our economic task force, has been meeting with relevant committees all over Capitol Hill. And we've been trying to educate members of Congress about what you're going through every day in the field. And that's my report. Thanks.
Well, thank you, Ken. And we appreciate everything that you're doing to try to help us legislatively up on Capitol Hill. Our next speaker is from, again, our Coronavirus Task Force, and she's been putting in overtime looking at the N95s and the other type of respirators that we are receiving, and that is Dr. Cristina Baxter. So Dr. Baxter, you now have the floor.
Thanks, Chief Ludwig. I want to first start out and just use a slide that I used last week, and this is just to remind you that the FDA did put out an emergency use authorization on March 24th, 2020, and then they followed it up the week later in the beginning of April, and that allows us the capability to use things other than NIOSH approved N95s. Now, obviously, as with any time, the NIOSH approved approach is going to be our best case scenario for us, but as we start having more and more difficulties getting a hold of materials, we end up going out to things like the European Union FFP2 or the Chinese KN95 and so on. But one of the issues that we're coming across is people understanding how to determine whether a product is appropriate or is actually a fraudulent product. So that's what we're going to talk about today. So if we go to the next one, this is just a quick way, and doesn't cover all of the elements, but a quick way for you to look at a product that claims NIOSH approval and just check and make sure that it meets those requirements. So the first thing you can do is just look at the mask. On the mask, it will have the name of the approval holder, so that could be as simple as 3M. It has NIOSH either in block letters or showing the NIOSH logo. It has what's called a TC number, which is a testing and certification approval number that always starts with TC-84A and then generally 4 numbers behind it. There'll be a filter designation, so it'll either say N, R, or P, so not oil proof, pretty much oil proof, and proof. And then filter efficiency level. So we're going to have a 95, a 99, or a 100. And that just represents 95% stoppage of the particles at 0.3 microns, 99%, or 99.97%. And then, of course, the model number of the product. So the lot number is also recommended, and you'll see that on many masks today. But one other way to go and check, if you're not seeing the things or if you're unsure just by looking at the mask, you can go to the NIOSH certified equipment list. Now, there's a couple of different lists you can use. I generally choose to use the certified equipment list because it leaves me a little bit more flexibility. So the website address is on the screen, but you can go through, and I always click on advanced search. And when I go there, I can go under schedules, and I always pick 84A because that's going to be my filtering face piece respirators of interest. Then scroll down to protections and select N95. And then you can pick the manufacturer brand, and then the output will give you a list of everything they have that's certified against it. The reason I like to go this approach versus the standard lookup table is that if you don't know the full name of the approval holder, it can be problematic. So now something as simple as 3M, like I said, easy. You look up 3M and it has the full name. But if you get to something, some of the other names where it's a long name and they have an acronym that they use, you may not be able to find it as easily. So let's go to the next slide for an example. So these are some of the common difficulties, and this one is actually the Gerson 1730. The reason I use this one is because it is one of the masks that we have in the national stockpile. So a lot of folks got this one, and all of a sudden you look and it says Gerson, so there's the manufacturer. It says 1730 for the model number. It says NIOSH for certification, and it says N95 particulate respirator. But you'll notice right away that there's no TC number. And so I've gotten this one several times where people send it to me going, there's no TC number. Does this mean this is a fake mask? And the reality is, if you look at the center of the screen, the requirement to put the TC number did not come out until September of 2008. If you look at when the stockpile products were procured, was actually in 2006. So you should expect, if you're getting the material from the national stockpile, that it may not have that TC number on it. And that's okay, because if you're getting it from the national stockpile, you know that it's been validated and lot tested to make sure that everything's safe. And that they did all this testing just to extend the life and to know that it was okay. As I said on the first page, on the NIOSH IT architecture is a little bit outdated. So if I'm only using the search, the simple search for N95s where you go by manufacturer, if I went to G to look for Gerson, I wouldn't find them. And the reason behind that is that they're under Louis M. Gerson is the name of the company. So I would really need to go to L. So I have a better chance of searching through the certified equipment list versus the manufacturer's list alphabetically, because if I typed in Gerson, it would still find it. And then the other thing that I had problems with this same mask was that their approval number was 84A-0160. On all of their documents, it just said 84A-160. So they truncated that front 0. And that made it impossible to find on the databases because their number is actually a 4-digit number starting with 0. So there's a lot of different things, and this is the simplest of them, is the NIOSH. So let's go to the next page, and we'll look at one from another country. So when I'm looking at KN95s, which appears to be what most people, I would say, are getting either the European Union or the Chinese KNs. So I look immediately for FDA registration. FDA registration is not required during this emergency use authorization. However, most vendors have done the registration. The registration is no more difficult than going online and filling in your paperwork for registration. It's not an approval process. You're not sending data in to get things approved. It's just registering that you're planning to, under this emergency use authorization, sell these in the United States. So the first thing I always do is go to FDA and say, did they even do their due diligence? So then I look for their test data. So every one of these products should come with some test data. So when I look at the test data, obviously it's generally in Chinese, and I don't read Chinese. But what I can do is try to compare that data and look for the numbers that make sense to me. I also can look and say, is that company that did the testing a valid entity in China? So you're going to be looking for a Chinese standards number, and we'll get into that in a minute. Looking again, is the mask CE registered? Are they registered for sale in the European Union? And if so, can you validate that certificate? One thing that I want to bring to your attention that's right in the middle of the page is NIOSH just started this new capability specifically in response to COVID-19. And what they've done is if you have a product that is coming in internationally and you need to have the lots checked just to make sure that they actually work, then they'll do that testing for you. So I put a couple in here, and you can see if you look to the back picture, there's some that are meeting that 99%, the 97%. But the ones that I pulled up in the middle, this is where the problem came in. There's a product, that lower one, that was only getting 24 to 35% particulate efficiency. So when your expectation is 95%, and you have that front person who is up front working a patient and they're only getting 24% of the particles stopped, that's scary. Now they would have been just as good in a medical mask versus a KN95 protective mask. So let's go to the next page real quick and look at a few more examples here. So this is still a KN95, but this is one that I've gone through and done the evaluation on. So I have the picture. It has the appropriate markings, KN95 on the mask. Right above it, you'll see that GTT, and then you'll see all the way to the right something called CNAS, C-N-A-S. And that's the standards agency in China. So I know they have the CNAS logo and they have the GTT. I went and checked and said, is GTT a certified organization for the test method? If I come across and you're in that second column of the data table, you'll see the 266-2006. That's the test method. And I start going across. As I compare it to the table we provided on the first slide, you'll see that it's going up to 85 liters per minute. You go across the table, 85 liters per minute. It's testing sodium chloride. You see the sodium chloride, and you see that it's getting greater than 95% removal. You also see all the different ones that they measured and that they're all getting greater than 95%. So it's about matching up the numbers that you can match up. I also was able to look at this product and see that it was FDA certified. Checked the product name, went into the FDA registration and said they're there. They were cross-certified as a filtering face piece respirator in the European Union. So when they had a CE marking on there, I was able to track that back and look at the certification letter and make sure that came from an approved agency. So as you can imagine, it takes quite some time. Generally, it takes me at least an hour per mask to figure out if they're real or not. So let's go to the next one. This is one that jumped to my eyes right away because everything looked really good with all their paperwork. So I had gone through, I had compared all of their test data and shown that they really showed nice test data. But then when I went to their certification, it was from an agency in Poland called ICR Polska. So I went to the ICR Polska website in Polish, and then on the top right, they had a little thing you can click that'll do the Google Translate into English. So I clicked on that, and then I was able to go through and find out that they had a certificate number search. And so I typed in the certificate that was with the materials and found out that, sure enough, that was a fake certificate that they were aware of. So I was able to quickly look back and see that while they were registered with FDA, the CE mark that they were using was fraudulent. So then you start looking, and one thing I want you to all be aware of is the difference between a CE mark and a China export mark, because they both use CE. So if you look at these, you'll see that on the CE mark from the European Union, the inside of the C will create a perfect circle, and that circle ends where the E begins. So the E starts on the inside of the C's circle. So if you look at those marks down below, you'll see that the China export, in order to avoid copyright or trademark infringement, slides their E over closer. So if that C on the inside could not create a perfect O, then you know that that CE mark is actually China export, not the CE for the European Union. So let's go to the next one. Now, this is what I was telling you about in the very beginning. MPPTL developed this capability that's specifically in response to the COVID-19 pandemic. And so what they're allowing us to do is submit different equipment that we have, and you can see over to the right, there is a very simple form that you fill out, and then you send that information in to the CDC website, and then they will contact you with any testing that they can do, or if in fact they've already done some testing. So that table I showed you right up front with all the fraudulent data was straight from the CDC's website. So if you go on here, it's cdc.gov/NIOSH/MPPTL for the National Personal Protection Technology Laboratory, and then respirators, testing, and non-NIOSH. So these are all just quick ways to try to figure out whether your product is in fact a true product or a fake, because as you could imagine, if you're using this as your frontline respiratory protection, we need to ensure that that is providing us the true protection that we're looking for. And with that, Chief Ludwig, I'm going to turn it back over to you.
All right. Thank you, Christina. Again, very useful information. I'm always sitting here with my mouth open with all the stuff that you are able to tell us about, and just the length and extent some of these companies will go to create fake respirators. So thank you so much for that valuable information. I'm now going to turn it over to another friend of mine, Mike Ragone. Mike and I have known each other for probably over 20 years, Mike. But Mike serves as the Chief of Fire in Federal Services for Global Medical Response. And you might have heard a couple weeks ago that in New York City, they had to mobilize about 250 ambulances into the city to help them with the surge that they were having. And so Mike was at the tip of the spear on that. And Mike's going to share with us some of those experiences and other things. So Mike, I'm turning it over to you right now then.
Thank you, Chief Ludwig. So if we can go to the next slide. So it actually began much before, a couple of weeks ago, on basically the 23rd of January. Department of Homeland Security asked us if we would assist with screening at all of the major airports. So we rolled out a screening program at the end of January through much of the March, or through much of February. And what that was our indoctrination to COVID. Really wasn't here. As you can see from the timeline, you know, we had some updates to that period, but we really did get to work with COVID much earlier than I think most departments in the country. As we went through this, we activated our command center on January 28th, actually, and we've been live ever since that point. And you can see through the timelines, again, I know there's a lot of little pieces, and I'll talk through some of these pieces, but including some lessons learned as we went through, because I got to tell you, there really wasn't a book that wrote any of this in there. So if you go next slide, these were some of the events that we got to work on right out of the gate, right? So I think you've all been aware, I know certainly the fire service is very aware of the Seattle evacuation. We ended up getting several folks quarantined off of that. The Grand Princess, statewide transportations, things like that, the Air Force bases. And as you can imagine, we got to see this across the country as it moved across the country and implemented in different areas. Some of the things that we implemented early on, if you will, are sharing of resources between our business units. So we established regional logistics teams that could actually move supplies between business units. As you've all experienced the shortness or shortage of all the PPEs out there. So we were able to take places that had extra, move them to places that didn't have enough, and shore that up pretty well. I mean, it did help us some, still running dramatically short as everybody else in the country is with that sort of stuff. So the other thing we started doing was implementing some tools, and I'll share those tools just in a little bit, but we implemented them early, which actually helped us once the real onslaught came for us. So if we go next slide, Gary talked about the fact that we implemented and responded to New York. And so what that is under the FEMA contract, typically we would respond to, let's say, a Florida, and Florida has a hurricane, and we would not use any of the impacted in Florida assets or any of the caller states to that under the federal deployment. Unfortunately, this was a little different than that. And in fact, it was very challenging in the beginning that states were like, okay, we're bunkering down, we're hunkering down. And there was a lot of pushback from states, don't take our assets, don't move our stuff. And it really became interesting because one of the rules in the contract says you can't use any states that has declared an emergency or a disaster. As a disaster declaration, well, that was pretty obvious. They were all almost there. So the initial infusion actually on March 28th into New York was 250 ambulances, which subsequently has been supplemented with another 100 ambulances. So when we got to New York City to support certainly Fidney and the surrounding area, at that point they were probably 400 to 500 calls behind. I mean, the surge was very dramatic. And in fairly short order, we were able to help them get caught up so that there were not calls pending. Didn't mean it wasn't very busy. Our units were running about 1,000 calls a day at that point, and we sent these in. Now, the interesting part here, and I think this is the conversation that John Sinclair brought up earlier, is, okay, how do you deploy to these things that you typically send base camps? Because we're a full wraparound service. We go in and we are self-sufficient, but you can't do base camps anymore. So how do you do that? So we really had to modify our model, and this is going to sound a little wonky, but we actually indicated that there could only be male, female teams in each ambulance, so that the housing arrangements would be those same teams, right? So if a strike team went down range with a strike team leader / safety officer, those two people stayed in that ambulance during the day, and those two people stayed in the same room at night. And so you really did stop the cross-contamination. The other thing we implemented was they wore surgical masks all the time when downrange, when they were socializing. As you can imagine, you got a lot of people there. We had to implement some different policies than you would typically do in a base camp, such as you're getting ready to for the wildland fires. Go next slide. The sequel, New Jersey. So New Jersey asked for 75 ambulances, then subsequently another 100 ambulances. And we continue to run missions in New Jersey, just literally across the bridge. And again, the same things are there, but we've learned, and actually we learned from the hurricanes last year, but what we embedded into each of these quote unquote base camps is we put a nurse practitioner in, so that the nurse practitioner, it's like your urgent care for your caregivers. We put an infectious control nurse downrange also. The mental health aspects, we actually have the state mental health in both New York and New Jersey, goes to the hotel at the end of the shifts as they're coming, and they're met with a mental health professional. The other thing we do is we actually have phone calls that folks can make, and early in this process, we implemented a process where they would call into a nurse advice line to go through their quote unquote exposure or concerns. That quickly became overrun, and we created an electronic app that actually would allow us to do that. So we'll talk a little bit more about that in just a second. We go next slide. So one of the things that we got presented with early in this disaster was the supply chain, right? So everybody's really concerned about the supply chain. So FedEx actually has about 8,500 workers at their Memphis hub. Gary's very familiar with that, as he used to be there in terms of Memphis fire, but this was critical. To us, this was critical infrastructure. If I can't FedEx stuff, if I can't move stuff throughout the country or the world, we're going to be in trouble pretty fast. So we helped them and set up a full screening process, so a massive screener that every shift trade we're looking for, going through the questions and screening every employee through the FedEx hubs. That's since been expanded to all of the FedEx hubs to try and protect the supply chain. And to us, that was one of those critical infrastructures. So go to the next, please. So these are some of the things we implemented. And it says the MASS tool. What the MASS tool is simply going through the criteria. So what we found is everybody under the sun started reaching out to us in terms of our crews with, gee, I walked through the room of somebody that may have had COVID. It's a person of interest, those kind of things. And those calls get overwhelming. But I got to tell you, they're emotional for the person that did it. So we developed an online app that actually would take the person through their questions. Did this occur? Did this occur? And it would give them an output. And some of those outputs were call the nurse advice line, and then a nurse would actually walk them through those kind of things. So one of the things, when somebody would get quarantined, we would actually take them off, give them direction to be quarantined, but we followed up electronically actually every 12 hours, and they had to take their vitals and everything like that during that period of time. But we found there was another back-end process that was missing. And so I don't know how many of you have thought through the next step of that. I'm now quarantined, I'm now at home, I don't know what to do. We actually have what's called GMR Life, a person that she actually comes out of Aurora Fire. She's done a lot of, Rhonda has done a lot of work with Aurora Fire, and she implemented a program that we actually physically call these folks back and walk through what their personal situation is. And that could be anything from, I've been exposed, I'm not going home, my wife and kid don't want me to come home, what do I do? And so we work through individual solutions with every one of those folks. And if those of you that haven't gotten anybody exposed, congratulations, I really applaud you. Those that have, the emotional trauma that it's creating on your folks. And to give you an idea for us, we've had 1,031 people exposed, of which I can thankfully say we only have 52 quarantined today, and we've had 101 positive cases of the COVID within our organization. And so as you can imagine, it's a whole workforce just to measure and monitor those folks. But I got to tell you, the mental anguish that I've seen our folks go through from, I'm not going home, I'm never going to go home, my wife and kids don't want, I'm going home, but my wife and kids aren't. We had so many gyrations of that on top of that back end well-being of, am I being paid? Am I not being paid? We elected early in this progression to pay folks with, if it was quote unquote work related, you got paid. You got paid the time on the beach. We found out very quickly that you can't really determine if it's work related or not. And so pretty much everybody got paid on the beach. And that was just a decision we made early. And I think the next slide. Some of the documents that we have. So this has been rapid fire. In fact, one of the criticisms I've had of many of the task force that I'm on is we're putting out so much information. And what's the true north? So we actually began to titrate it back and give one source of information. So we established a QR code that anybody with their phone can simply walk up to that QR code, take the picture of the QR code. It will take you to the most recent stuff. We've and you're welcome to go to our website. We chose early on to open up our information. Anybody's allowed to look at it. Anybody's allowed to use it. And you know, we opened that all up. But for us, it was trying to search through a website really was challenging. And so we developed the QR code, which takes them to the most recent information of everything they've got, from decontamination to all the things you're seeing on the screen. Implemented a fogging process and things like that. Because again, if I don't know if I'm contaminated, what does that look like? It's invisible. I can't see it. I need some assurances. So next slide, which is the biggie, right? So this is where I sit today, very fearful of what mentally we've done. So we got several requests, both in the state of New York and the state of New Jersey, to move dead bodies. Would we be willing to be that workforce to move dead bodies? And quite frankly, I elected not to do that. I get it. We've all seen dead bodies, those kind of things. But at the end of the day, you can't unsee it. And so we've elected to avoid that level of work because I'm real fearful of the mental anguishes that this is creating downstream. And literally have created a mental health program that not only follows them through their time in theater, but also through the discharge and then follow up. And they can simply call a mental health professional and then get referred into the program. I think we can't cheap out on that as organizations because this is traumatic. It's seems to be much more traumatic to our folks than ever has been. So again, I could spend a day on every one of these topics and what we've done, but I leave that to you because I think we're just about out of time.
Well, thank you, Mike. That's a whole lot of information. You and I haven't had a chance to catch up. Are you still working out of your operations center down there in Dallas? Is that where you're at these days?
Yep. I'm still here. Been here the whole time. So we're and don't seem to think we're getting out of here anytime soon. Okay.
Well, my thoughts and prayers to you and all your staff and all the members of your organization and to everyone in the fire and EMS service also. Let's just pray that we get no more infections and we lose no more people. We've lost too many people in this war so far. So I just want to thank all our panelists today who provided this outstanding information. I also want to thank Chief Sinclair, Chief Pegram, Chief Jenkins, who are all sharing different task forces for me. And finally, I want to thank our interim CEO, Rob Brown, and members of the IAFC staff who are working many long hours and weekends through this crisis. For those of you who are listening today, if you have any questions, please email them to covid19tf@iafc.org. Again, that's covid19tf@iafc.org. As a reminder, we will be doing these webinars every Monday at 4 p.m. Eastern Standard Time. And in the future, we'll also include not only information from our subject matter experts you heard today, but also from our economic task force and also from our innovations task force. To register, please go to iafc.org. I'm honored to serve in this noble profession with so many of you who make a difference in their communities every day. Please join us on our webinar next week as we provide the latest updates and vital information. Everyone, please stay safe. God bless you, and may God bless these United States of America.
Thanks, Gary.
Thank you all. I appreciate it. It's great information again today.